So then this is what I plan to do, to talk very briefly about mental health in humanitarian settings, because that is a bit different from the regular context of, let's say, a development setting or a non-emergency affected setting, just very briefly. Then I would like to talk about how in UNHCR we work with the mhGAP, the tool that is central, how we have tried and also sometimes struggle in using it in very resource poor settings. So I'll try to be as honest as I can and as I dare to be with you, because I think it's a great tool, mhGAP, but it needs investment, dedication, and it is not a magic bullet. I want to have said that before. I think it's a great tool. It can be a game changer, but it's not something that you can just say, oh, we spend a little money and we throw it and then it's done. It needs continuous attention. Now, and then I want to end with 2 examples. Let's see how much time I can have. One is briefly about the Rohingya experience in Bangladesh, where you have, of course, 1 million refugees in Bangladesh from the Rohingya community, and we do work with mhGAP. So I want to share a little bit. It didn't work very well initially when it was a small refugee setting 7-8 years ago, and the last years it works very well, and I want to explain with you why it has improved. And then I want to end with Afghanistan because I'm thinking a lot about that country last days. Is that okay, Asma?
This is great, Peter. Thank you.
Perfect. So then I start with this first point. I want to talk first a little bit about prevalence of mental health issues, because that is an ongoing discussion. But in general, what we use in UNHCR are these figures. Maybe they have been shown, but these are the figures, the estimated figures for mental health problems in areas affected by conflict. So it's a kind of meta-analysis using studies in areas where the last 10 years has been a major conflict, major armed conflict. And the data are corrected for, let's say, methodological flaws. So there are some techniques which I don't really understand, but that comes up with credible figures. That is important because we all know that some research is a bit quick and dirty. If you ask people, do you feel sad? Probably everyone in Afghanistan will say yes. It doesn't mean they have a depression, to give it a very simple, example. So if you look more carefully, particularly prioritizing clinical instruments, these are the figures that I think are credible and that we use for advocacy as well. So that means around 1 in 5, 22% of the adults, we don't have the figures for children, but it will probably be the same. 1 in 5 of the adults in a conflict affected setting have a significant mental health problem. And that's a lot. That is about 2 to 3 times more than in a non-conflict setting. If you use the same methodology, I know you have different epidemiological data. Even for Pakistan, you can find data from the early 2000s with higher figures. But this is like if you use the more conservative estimates and you compare it. So it's about 2 to 3 times more in conflict-affected settings, which would obviously include some of the areas in your country. I think of Khyber Pakhtunkhwa, where actually they had their share of armed conflict in the last decade. If you look then at the division of problems, then you see that around 5% have severe mental health issues. So that includes what we traditionally call severe mental disorders, everything related to psychosis, bipolar disorder, which most likely is a little bit higher in post-conflict settings. That's relatively a new finding, because when I was studying, I heard a lot about genetic causes of schizophrenia, which probably is true, but not the whole story, because actually we don't know the cause, as you all know. But it becomes more and more clear that trauma, childhood trauma, and adversity in childhood has a negative effect on the prevalence of schizophrenia. So it is actually likely that also psychotic disorders actually are more increased in conflict settings. And another reason is, of course, that even if the neurobiological vulnerability is the same, the expression of the problem will be more if all your support systems fall down. You can imagine if you have someone who lives quietly, let's say in a village in the Punjab, and can manage, but he may not be diagnosed as having psychosis or schizophrenia because it doesn't manifest. He has the support around him, family system, community system. And then imagine that that person gets into a war and the village is bombed and he has to flee and he loses all his support systems and there is a lot of stress. You can clearly imagine that that person then becomes symptomatic. So it makes sense that in conflict settings, severe mental disorders are increased. I must say this also includes very severe forms of depression and post-traumatic stress disorder. In their severe forms, those are severe mental disorders. So that's around 5%. That means around 1 in 20. That's still really a lot. 1 in 20, that's really a lot. And then you see the figures for people with moderate and mild mental disorders. Now, sometimes people then ask me, and they say, Peter, yeah, but what about these data that we hear from Afghanistan or from other war-affected settings where you see much higher prevalence figures? Well, my answer here would be that you probably conflate mental disorders, frank mental disorders, true mental disorders, with psychosocial distress. People can be very distressed because of their situation. That doesn't mean they have a treatable mental disorder. So yes, of course, currently people in Kabul, they will sleep badly, they will be worried, they will maybe think the future, have a bleak outlook for the future, but that's of course not a depression. So I think we need to distinguish between psychosocial issues, which mainly have to be solved within the social systems where people are. So you talk about social work, you talk about community workers, and mental disorders where you would actually want to have some medical involvement. Now, you can criticize me because the distinction between those two is not so easy to make. It's partially about symptoms, the typical symptoms of depression, the typical symptoms of PTSD, combined with loss of function. When a person is still able to do everything, maybe one of you actually doesn't feel very well, but you're still able to function, I would not say you have a mental disorder then. And of course, the distinction between severe and mild mental disorders that you saw in the data from WHO is also very fluid. When does it become severe? That's also quite problematic. But as a kind of general tool, I think it's important to look at the spectrum of problems, where we as psychiatrists or medical people need to be most involved in the severe part of the spectrum and have more an advisory role in the other parts of the spectrum. Now, another slide I want to show you is that when it comes to distress in refugee settings or acute war zones, you often see a kind of pattern where initially you have high levels of distress, but later on people are able to cope. I will tell you, the people in Afghanistan will cope with their situation. It may not be good, but they're strong. And so I think a lot of the current distress will somehow be mitigated when people find their ways. So you will see then it will go down again, but not to the level of the origin, but it goes down a bit. And then, of course, when the situation continues, like we have seen in the Rohingya setting, which I will tell later, in Bangladesh, where some refugees were in really bad situations for decades. Some people were even born in a refugee camp, a small refugee camp with a corner, with a wall around it, and they were not allowed to leave it, were not allowed to go to school. Yes, of course, you see the problems going up again. People lose hope, people start to have bad coping mechanisms. So this is a bit the patterns that we distinguish within MHPSS, within mental health and psychosocial support. Now, how to address these issues? I cannot go deeply into it, but I want you to know about it. So we have tools. This is a very boring document, the ISC guidelines for mental health and psychosocial support in emergency settings. You can read it. It's already from 2007. But that's not the essence. What I want you to know that it exists, and I want you to know that within this humanitarian MHPSS field, we see specialized services, which often is what we do as trained psychiatrists or medical doctors, is only one part of the spectrum of services. So let's start with the bottom layer. It's very important to, particularly in humanitarian settings, displaced populations, that you do all assistance in a way that is good for mental health, which means that you try to listen to people, you try to use culturally appropriate methods, you try to make sure that people have basic services and have access to basic services, because that's what people worry about. I will tell you, most Afghans now will not worry about the Taliban. They will worry about whether they will still have money to buy food in the next weeks, and whether there will still be health services. That's what they will worry about. So of course you need to address these basic needs and do that in ways that are good for mental health. Then the layer above, strengthening community and family support. I think when you are distressed, you initially seek support within your natural environment. If I feel bad, I go to my friend, or I go to my neighbor, or maybe I go to church, or you may go to a mosque or whatever, but you do things that are readily available. However, in war zones, all that is destroyed. So logically, we have to rebuild it. We have to rebuild the social and community ties, which is not something a psychiatrist should do, but we need to advocate for it. And this is work of social work, protection workers, and of course, communities themselves. And then we go to the top layers, which basically is person-to-person support. That you have a person as a mental health issue, can be anything, and he's not able to solve it within his own environment. So he needs help from outside. Now, the difference between the two layers is that the top layer means us, specialists, that those who are in the specialized level need to see people with complex issues, people just who for whatever reason ends up in your service, but they need also to have a large role in training and supervising people on the layer below. Well, I think you got that message through, Asma, loud and clear, but I think that's really a game change for mental health professionals. So a little bit at the mhGAP-HIG. This I will do very briefly, because I assume you have been told that. When we talk about the mhGAP intervention guide, we have actually three. We have the original one, 2010. We have the new one, you see left below, the 2.0, we call that, from 2016. And we have the one on the right, which is the 2015 one. I think you have been told, I see people nodding, so I will not go into this. And then you have lots of supportive materials that you can see here, like a guidance on how to train, how to supervise, how to do a kind of contextual analysis. We call it the operations manual. And what I have to say, which you may not have been told, that we are in the very, very, very final phases of releasing the mhGAP facilitator, mhGAP-HIG, so the humanitarian version, facilitator guide. There used to be one for some modules, but the one that covers the whole HIG is about to be released. And I think, Asma, if you don't yet have it, be in touch with me, because I think that WHO will be willing to, well, I can't talk for them, but I hope they will be willing to share it with you.
Will do.
Yeah. So then this is the mhGAP-HIG. I will not go into it because you know it. This is developed by WHO together with UNHCR. As you know, you see our logo on it. And the reason is that we wanted a tool that was even briefer and even more adapted to humanitarian settings. So then in 2015, that guide was released, and then UNHCR started to introduce it particularly in Africa. We couldn't do that by ourselves, so we recruited an NGO, the War Trauma Foundation, and they developed a program for training mhGAP-HIG. But what we asked them to do is to not only look at the medical providers. So they did something which I like, but we haven't really pushed for that globally. What they actually did is they did 2 parallel trainings. One is the classical training that you are familiar with, where you train medical staff, or perhaps it could be medical doctors. I don't know the terminology in Pakistan, but it could be people who have less education than a doctor. So it could be a nurse who has the authority to also prescribe medication, for example. And in Africa, you have different layers of support where we call it medical assistants or medical officers who are not clinical officers. Anyway, so they trained the medical people in one group, and then simultaneously, ideally in the group next to it, they trained non-health people, which could be social workers, which could be people working in what we call protection staff. Some of them were psychologists, but not clinical, and also refugees themselves, refugee health workers. So they were trained separately. The problem is, of course, that the mhGAP-HIG, as you know it, is totally unsuitable for this group because it's too medical. So they juggled a bit with it. They made some adaptations, and they tried basically to focus on what a non-medically trained person can do using the concepts of the mhGAP, which mainly is identification of people, and also the support once people have been seen by a medically trained person. I think that is an important part, and I think it's something you need to think about as well, how you're going to do that, because to be very honest, we don't have very good tools at the moment internationally. So we have the HIG, we have the facilitators guide, we have from WHO now the community mhGAP tool that you may know. It's worthwhile to look at it. However, I find it still too high level, too process oriented. I want it to be more concrete. I want to have tools that you can really use when you train community volunteers. Or in Pakistan, I think you have this very nice concept of the lady health volunteer. I don't know if it still exists, but those kind of people, you cannot use the mhGAP-HIG as it is, because it will confuse them and even make them do the wrong thing. So you need to adapt your training tools to have these non-medical people. The War Trauma Foundation did that a bit on their own. I can share the materials with you, but it's not super good. Well, I shouldn't say that. You're recording it, Asma. This is very bad what I'm saying. Knock it out. It's very good, but it may not be, you may not be able to reproduce it everywhere. Let's call it like this. Now, what did we do? This has just some data, just from the first 2 years alone. You see it's mainly focusing on Africa, where we did trainings, basic trainings. Oh, what I forgot to say, let me go one slide back. What is very essential in the model that War Trauma Foundation developed is that they did these 4-day parallel trainings, but day 5 was joint. And that's essential. So then you're going to have more like a workshop when you say, okay, now the people in the health facility have been trained to do this. You in the community have been informed about mental health issues and blah, blah. How can you work together? What can you do? How can you make a referral mechanism? How can you make a plan for supervision? How can you work together? You cannot prescribe that. You cannot tell them what to do. You need to do that bottom up. You need to sit with them and say, okay, what can you contribute? How can you do it? Yeah. And that worked very nice. That really galvanized the attention for mental health in the refugee camps, because this was mainly done in camps. Here you see some of the numbers in these first 2 years. So we worked hard in really remote places, as you can see, mostly in Africa. We continue training. We have more people trained, but we wrote an article based on an evaluation around this mhGAP-HIG in refugee settings. So you can find the tool, or I can send it to Asma if you wish. Basically, we looked here at, I'm not sure if you can see it, it may not be clearly enough, maybe too small, but what you see here are the different countries where we worked. With the blue one is whether the knowledge has increased. It's just the difference between baseline and after the training. So the percentage of increase in knowledge and in technical skills and in case management skills. And what you see is that there is in some countries quite some increase in knowledge, but in some countries not, because the knowledge wasn't the issue. People knew, particularly the medical doctors, they knew some things. They knew what a psychosis was. But the bigger differences are in the technical skills, like how to actually manage a person with mental health issues, and in case management skills, like how do you really manage a case, which are more the soft skills, like how do you increase or improve the relation with the patient and the family. So these are core case management skills, which have nothing to do with whether you know all the diagnostic criteria, but whether you're able to convince a person to stay with you. So that's why we saw the biggest changes. Now, the external evaluator was a experienced humanitarian psychiatrist, concluded that the HIG is really a valuable tool in low resource settings. It had really led to increased competency and to enhanced collaboration between particularly health and non-health. It has also led to a standardization of clinical practice, because particularly in humanitarian work, where you have people flying in from all kinds of settings, you sometimes see really lack of standard tools. So one person will be much more easy in diagnosing depression than another person. So it leads to standardization. And in general, it generates attention, which I think Asma will also have noticed, that if you start doing this, you somehow generate attention for a forgotten subject. And instead of people thinking that, yes, mental health is for that odd one who works in psychiatry, people start to realize it's something that is for every person involved in healthcare. And that is really a major change. The challenge that we faced, and I will be very honest with you, was the difficulties we had in installing supervision systems. We did our best, but it's really difficult if you work in a country like Chad, which has about, I think, 20 million people. It has one psychiatrist in the capital, and the country is huge. So a supervision system was problematic, and sometimes we just failed to give proper supervision. So I really hope that you, because I think you're in a bit better place now in Pakistan, you have slightly more mental health professionals, but also you have these days the infrastructure, like the online training you're doing now, but also, well, infrastructure in Pakistan, fortunately, is not comparable with some of the settings that I worked in Africa. The other thing is that, yeah, something we do in humanitarian settings, we come in, we bring in an international NGO, we do our work, but it's not related to the national system. So that's why I immediately had to accept Asma's invitation to come here, because you work from the government, which sometimes is not a blessing, because things go slow, there may be bureaucracy, but in the end, when it comes to sustainability, this is what you need. And yeah, so, and the last point is that, yes, these community health workers need their own approach, and we still do not have very good tools. So I think you also need to use your own creativity and your knowledge of the context. So yeah, mhGAP is not a magic bullet, and I think the most important lesson learned is that capacity building is not a process. It's not a matter of doing 5 days of training, tick the box and you're done. It is a continuous process. And often the learning, the most significant learning, takes place in the supervision sessions, when people come back and say, listen, I saw a patient and I saw this and that, but I don't understand. Then people start to get engaged. Secondly, of course, the critical role of supervision. Thirdly, the cultural adaptations, which is, I think, less the case for you because you are from Pakistan. Although you may be, if I may say so, some of you may be very urban, while the people you work with are very rural. So it may still need you to go a notch down and speak the language of the people that you work with. And I don't mean, well, sometimes literally, because not everybody speaks Urdu in some remote areas as well, but also particularly, of course, the kind of words that you use. And then, of course, need to know that mhGAP will not equip people to do everything. So particularly there are people, particularly with psychotic disorders, you do everything that mhGAP tells you to do, and the person is still very symptomatic. That happens because that's the nature of the disease, of course, but that does need kind of approach beyond mhGAP. So we wrote an article, you see it in the on the bottom right, which was actually what to do when the steps in mhGAP are gone. And one of the things is that we found out, we don't use it, but that clozapine really has an added value on top of haloperidol and the medication we use like olanzapine or risperidone. However, it's of course very complicated to use it. So I would never do that in primary care, but to go from haloperidol to glorpromazine, it's then better to go from haloperidol to one of the atypical antipsychotics, which is not clear if you look at the mhGAP. They say choose one of those, but the question then is what to do if it doesn't work. Anyway, this is a bit too specialist, but we did a systematic review around that. Yeah, let's go. This actually is what I wanted to say about mhGAP and how we use it in UNHCR. We're still using it, so we still do trainings in every year in the low resource settings, but it's less and less led by the head office. It's more and more done locally. So, for example, a country that Asma knows well these days, Sudan. Very complicated country with very, very limited mental health resources. But due to the work of Peter Hughes and Asma and others, there is now a cadre of mhGAP trainers. So which makes it possible now to do an mhGAP training where you already build in the supervision by the trainers because they're national staff. So those are things that we do and where we know that we have bigger chances for success. But in some cases, like in Congo, in Chad, Cameroon, we failed because we couldn't set up that supervision system. Now, what I want to do now, other questions still now, I'm about halfway. If there are any questions still now, I'm very happy to take them.
Peter, I have a question.
Yes.
Of the different models of supervision that you have experienced, what has worked the best so far?
Well, I'm a bit old-fashioned, so I'm not sure I have thought it through and you will like it. But for me, what has worked best is if a person is able to regularly visit the spots. So I would, but that has to do with, of course, the realities of the terrain, if you're able to do that. But what I feel works most efficiently if you have a mental health specialist who can actually visit the clinics, because you see so many things actually that didn't come up when you do your training. When you see actually about how do people keep their records, how is the setup in the clinic. It can also be a good opportunity to talk with the clinic manager, because then you have a visitor from the capital or from the provincial capital, and then so you raise the attention for the topic. And of course you can see how in reality the trainee works with the patient, and you can do kind of mentoring. So if it's possible to arrange that, that would be still my preference. Now, that can, in our UNHCR guidance that we give to our operations, we say try to do that at least once per month. Easier said than done, because often we can't. We can't. But I would say strive for that. That at least each health center is visited once per month. And I think if you cannot do that because of all kinds of practical issues, try to do it at least sometimes. And then you can much more easily do the telephone supervision, the online supervision, because you've seen the people, you've built a rapport, you know how they work. So that's one thing. I'm not sure that's what you need. I don't know if that's an answer, Asma, actually.
Yes, it is, Peter. It's very helpful.
Okay, good.
I mean,
Okay.
in addition to what you have said, we've been thinking how to create an instant supervision. So rather than waiting for the whole month, because part of the supervision process inefficiency is because you have to collect cases, and at the end of the month or end of 2 weeks, you've almost forgotten what cases you saw. So how we are going to go around that is that we are developing a mobile application which will give a rough mhGAP-HIG in their hands also, but also they can immediately send a message that they need advice. And within 24 hours, one of the specialists will call them.
I would be super interested to see how that goes and see if we can use it in our settings, because that is what I usually say to people. You can call your supervisor, but it hardly happens. It's not like it's because they can't reach the person, but also they may be afraid of doing it. It's not in their, it's just not. I mean, I know in my training I could do that, and probably you in the tertiary care, you can reach your supervisor. But if you are in a rural clinic, then to go step out and call someone, it's just doesn't sufficiently happen. So if you can make it easy for them to do it with this app, I would be extremely interested to see how that functions and see if
Yes.
we can copy it.
I mean, I think one of the problems of making a call to the specialist is that the specialist might not be available 24/7.
Yes. Yes.
So sending an SOS, I think it gives a lot of flexibility for our system to call them back.
Yeah.
Also, what we are trying to do, which I think we could afford in ICT, maybe we'll not be able to afford it in other provinces or remote areas, is that the ratio between our specialist and tier 3 people who are going to be trained in mhGAP is very, very decent. At the moment,
yes,
it's nearly, like 2 people supervised by 1 specialist.
Okay, so they're in a good position. Yeah. Yes, because too often I see that the relation between supervisor and trainee becomes a bit of a controlling relation, where the supervisor is controlling whether the supervisee is following all steps, and that will make it difficult for the supervisee to show their weaknesses and their mistakes, because they try to hide it. So I think it's important that you really see it as a collaborative effort. You say, you have the knowledge of the context, you know the patient, you know the realities, and I have some additional capacity that you don't have, and together we will work in the interest of the patient. So that means actually that you yeah, I don't know, it's really the soft skills. It's really trying to not criticize the supervisee too much, even though there may be good reasons to criticize, but formulate it in a supportive way so that it strengthens the supervisee. I wanted to share an experience with the Rohingya refugees, which is a group that is close to my heart. You have all heard about them. It's really very people in a bad position. So there's people who live in one remote corner of Myanmar, former Burma, very close to the border with Pakistan, where they are culturally related with. They speak the same variant of Bengali, and the government of Myanmar doesn't consider them as Myanmar. So they said they are actually Bengali. That's how they call them. And what they mean with that term is they should go back to their country, which is Bangladesh, which is ridiculous, but anyway. So they're in a bad position for decades. And there have been waves of refugees over the last decades. And when I started working with UNHCR, there was a small pocket of around 50,000 refugees, no, even less, 30,000 official refugees in 2 camps in Bangladesh. And these camps were very crowded, and people couldn't leave the camp. It was really complicated. So we did trainings there. I went there a few times to do mhGAP trainings that you see on the left side. So we saw that we had an increased competency in the providers. We can do pre and post tests. We could see they had more knowledge. We could see they knew better what to do. However, they couldn't bring it in practice because, one, the medication supply was really problematic, because also the restrictions of the government to allow psychotropics to go to primary care level. The supervision was extremely problematic because the psychiatrists were in the capital, and there were few. Third point is that we found a resistance in the management of the health facilities. They just didn't think mental health was important, and they just didn't think it was worthwhile to invest in it. Identification. And at that time, in that operation, there were no mental health professionals. We started with one, Mahmouda, Bangladeshi psychologist. She started to work around 2014, and she slowly started to change things within that operation. She was a psychologist from Bangladesh. And it worked somehow. We saw improvements, but slowly. But then in 2018, this big influx of refugees came, actually end of 2017. And then in 2018, we again started to invest in mhGAP trainings. And strangely enough, suddenly we saw it made a difference. We could see it in the data in the number of people who were seen, the number of referrals. We could just see it worked. Why was that? I think partially because we now had medication, because this whole emergency brought a lot of attention for the Rohingya situation, also money, frankly, and also the government was a bit more lenient. So we could bring in medication, and also the number of Rohingya refugees that were there increased with 700,000. So that justified also to have a full-time psychiatrist in that setting. One psychiatrist for 1 million is not a luxury. One psychiatrist for 30,000 is actually not a good investment. So we suddenly could have a mental health professional from the country, and that helped because she could go to the clinics and do clinical supervision. It really helped. Also, the health facilities were a bit more motivated, and one thing which I'm really proud of, actually, to say, although it is more a policy thing than a clinical thing, we forced the health providers to accept it. Basically, UNHCR told them, when the NGOs, you have these NGOs like Relief International, all these NGOs who would have a contract with UNHCR to provide health services. We said you can only have a contract to be our primary healthcare provider if you include mental health. And some of them said, no, we cannot do that because we're not used to that. We are more focused on reproductive health and infectious diseases, and we don't have the knowledge. We said, don't worry. Our team will help you with the technical knowledge. You need to do, you need to allow your staff to be trained in mhGAP. We'll do the training, we'll do the supervision, but you need to allow them to be supervised by someone who's not from your organization. You need to buy the medication. You need to employ a psychologist, at least not in every health center, but in some of the health centers. And well, I think that was it, basically. And then they said, no, we cannot find psychologists because it's difficult in Bangladesh. It doesn't exist, or culturally, it's not possible in this context. And they had all kinds of stories. And we just said it's non-negotiable. If you do not include a mental health component, you cannot be our primary healthcare provider, because there is no healthcare without mental health care. Okay, well, to give you an overview, the picture on the left is an old camp. You can see that as well. Old, crowded. This is where Rohingya people were living. They were born there, some of them. And, well, to be sad, they may die there, because that was their life. Because it's really not fun to be a refugee, and certainly not to be a Rohingya refugee in that time. It's slightly better now, because you see the picture in 2018. That Rohingya camp has flourished, and it's now like a city. There is one of the biggest camp, Kutupalong, is 500,000 people. It's a major city now, with much better infrastructure. Still bad, but there is a vibe that things are going on. And unfortunately, we see now that, for reasons that I can partially understand, the government of Bangladesh is getting a little bit tired of the protracted setting, so they're trying to somehow relocate refugees or see if they can go back. So then the policy window is a bit less. I wanted to show you this picture of the system that worked in Bangladesh, which I think could be something you can learn from. It's on the top you have the psychiatrist, a few psychiatrists to do the management of severe mental health conditions, but particularly do the support and supervision for the mhGAP trained staff. We talk about 2 psychiatrists now in 1 million people in that setting. And that's not even true. 1 million Rohingya plus 2 million Bangladeshi. So we talk about 2 psychiatrists for 3 million people, 3 million. So they cannot do too much, but they can do something. Then you have the mhGAP trained medical staff. It's functional now. Then you have, which is important and something you cannot do everywhere, there are psychologists now in the health center, that's what I said, and also lay counselors. So there is a system now of lay counselors, we call them para-counselors, who are still non-specialists, but they have been trained quite well. So there is this system of para-counselors, and they are being trained now in doing case management. The psychologists have been trained in interpersonal therapy, which is one of the scalable psychological interventions. So we have an agreement with the team in New York that does these trainings for us. And IAT is a very unknown psychotherapy, which is, it means integrated adapt therapy. It's made by the group of Derek Sylov and Alvin Tai from Australia. And it's very much adapted to the refugee context and particularly to the Rohingya language. So I can share you the details, but I think it's important if you do mhGAP, if possible, that you also establish something of a counseling service, something where you can actually do simple treatment for depression and anxiety problems. Now, that's not always feasible. I realize that very well, but if possible, I think it helps, because in the end, the medically trained doctor will never have the time to do psychotherapy 7 sessions long for 45 minutes per session. That's not a good use of the time of a medical person. Then below that level, you have the psychosocial community health workers and psychosocial outreach volunteers. So that's the real volunteer group. They do community workshops, mainly awareness raising, but sometimes also peer support groups. And then below that, you have just general community workers, because there are lots of community workers, at least in humanitarian settings, who are trained in nutrition, who are trained in health, who are trained maybe in health promotion or hygiene. It's good to also train them, at least that they know a little bit. It can be a training of half a day, it can be very brief, maybe even 1 hour, but at least that you bring it to their radar. So now this is quite a complicated system, which we could do because we had relatively good funding in the Rohingya setting in that time. So we could build, you see, a pyramid of even 5 layers. Did that work? Yes, it did. These are some summary data. In 2020, I don't have the data of this year, the community-based activities attended almost 250,000 people. And those were just very simple things. I like community meetings to do awareness raising about mental health, to talk about anger management for men, which is an important issue. A lot of young angry men there, and issues like that. Then in the health centers, there were 57 general staff who were trained in mental health and were supervised. Oh, sorry. The number of consultations slowly grew, while the number of people in the camps did not grow. It's about the same. So you can really see, it's still not super many, but I think 7,000, almost 8,000 clinical consultations in health centers is already, it makes a difference. You can say on 1 million, it's still too little, which is true, but it's at least something. And I must say, these are all only the facilities supported by UNHCR. There are other ones that are supported by IOM or by others. So the real picture is a little bit better. And then we invested in these psychotherapies. So we trained 25 people in integrated adapt therapy and 23 in interpersonal therapy. And then the psychologists, as the last bullet, the psychologists and the para-counselors did more than 10,000 individual sessions in 1 year. So in the end, I think it's quite well. 5 things that need to be done in Afghanistan to have good data, to develop methodologies for integration of mental health in primary care, to really do capacity building on different levels, to have a monitoring system, and to train the medical staff. Now, I just tried to give you this because this was not now, this was written 20 years ago. This was actually my very first article, which was published in the Journal of Ayub Medical College, which was an editorial. And I think much of it is still valid, although in Afghanistan, a lot has been done. I will not go through that, but I will send you the data. But again, here you can see some data of in one of the clusters of districts in Nangarhar province. You see here the percentage of diagnosis in primary care related to mental health. These are not refugees, these are just the regular Afghan population. And you see initially it was almost nothing, it was 0.0%. And you see that over the years, we reached 4 to 8% of the diagnosis in primary care were related to mental health. What you see is it took a long time in the beginning, these first years, to build capacity, to build buy-in. And then you see it moves up. You may wonder why is why you see the drop in the last years. The drop in the last years was not so much that we saw less patients there, but the drop was more that other people got better care. So there was much better reproductive health care. So the percentage got down. And then I will stop. I will just want to show you, because I just want to show you, this is important here. Work with these people. I don't know if there is anyone who speaks Pashto, but these are the Spingari, or the Spingere, the white beards. If the white beards are against you, it's very difficult to work in a rural community. Work with the traditional birth attendants. That's a difficult one, but you have powerful women in communities, and you need to somehow involve them. And I think this is important. go to communities and work with them. You don't all have to do that, or I would invite you to do that because it's actually fun to do this. But this is how we did trainings for community workers. Well, that's it basically, and make good materials for health education. I can't resist it. I'm stealing your time, I know it. But what do we see here? Sarah, Faisal, what do we see? What is this? This picture. What does it show? Now, what I say when I ask this to psychiatrists, they always say, depression. They say, this is depression.
I was about to say that. Okay,
good. Then that's right. That's what people say. But the mental health professionals say, if you show this picture to women in an Afghan village, they won't say this is depression. They say, this woman is unhappy, which is the correct thing. This is what we see. We see an unhappy woman. Why is this woman unhappy? That's the question. Then you're going to talk, and they say, oh, maybe she's worrying about her children. Maybe she's worrying about her husband or her mother-in-law, always the mother-in-law in the Pashtun culture. So then you have a conversation with them. And then you're going to make the next step. That's this one. Oh, wait a minute. Here you see her again. You see she's very sad. That's true. But is it depression? Not all sadness is depression. Now you see them again. You see we go from right to left there. The bottom layer, you see the same woman. The upper one, you see a different woman. But she's also sad, you see. The upper one, the one with the pink scarf, you see on the left side, hey, what happens there? She gets something. She gets a present from a man. Well, I assume that's her husband. Could be her brother, but it's not a stranger. Then she would be in a very bad position. But she gets, and you see, she's smiling. So, but the bottom one, she gets a present, and what do you see? She's still unhappy. Now, what's the difference between those two women? And now you're going to talk with the women. And they say, oh, the bottom one is a bad woman because the husband is giving her something and she's still not happy. She's a very ungrateful woman. Then you're going to say, yeah, there could be, but could there be something else? And then there was, for example, the Afghan women would come and they say, no, this is not just sadness, this is deep sadness. The sadness is so deep that even well, basically, even if the situation changes, she still remains sad. And they say, that's the one we want to talk about. That's the one we want to talk about. And then we go to the next slide, well, which I don't have because my slides are gone. And then you're going to talk about additional symptoms. So this woman is not able to sleep. She loses her appetite. So basically, you are making the symptoms realistic. And it is more a conversation than that you are lecturing them, because they say, yes, this is me. You invariably will say that one of the women will say, but I have this. It's because the sadness is too much and the sadness is too deep. And then you say, well, that one, maybe she needs to talk with someone, or maybe she needs to see a doctor. So that's it. Khalas, finish, Bas, I'm over, I'm done.